everyone. I hope you're all feeling a bit refreshed after some strong coffee or tea. We're all ready to go here. Our first speaker is Mr. Muralidhara Prasad, and he's going to be speaking on active case finding strategy for TB case detection in urban slums. He actually has two presentations. So that's the title of this first one. And the one that will follow that will be on the experience of sputum collection and transportation in TB care and control. A bit about Dr. Prasad. Dr. Prasad is a national level public health specialist with nearly 10 years of experience in the health sector, and he focuses on health system strengthening.
Very good morning to all of you. I would like to thank IPH and ITM for accepting the abstract. What we are doing, what I am going to talk to you here about one of the almost neglected disease, which is called tuberculosis. Why I am saying neglected, I will come to through my presentations. I will explain you about it. So, what I am going to. Okay, that was good. Thank you. What I'm going to talk to you here about the strategy what we adopted for tuberculosis care and control in actually making people understand about tuberculosis in the community, and also going through the literature about what are the strategies they are proposing and how best we can implement it. Based on that, what we found that active case finding was one of the strategy which was proposed widely and discussed and debated, and now there is a turnaround from what we already known as passive case finding strategy. Most of you who are working in tuberculosis would understand what is passive case finding. Basically, a TB symptomatic is having cough for more than 2 weeks and is not able to sustain his cough, suppress his cough, and comes to the system on his own. And in the OPD, he has been diagnosed as a probable TB symptomatic, and he has been referred to the lab for getting his sputum examination. This is what we call as passive case finding. So what we did was, there was actually a challenge, basically, people understanding that I'm having cough more than 2 weeks, me going to the public health system. There was an element of delay in both the ways, from the public health system as well as from the patient in itself. So what we did was, we searched around literature, and what we found, there was about 3 ways of doing the case finding. So we clubbed this together to form what is known as community-based case finding strategy. Here we have, in community-based case finding strategy, we have enhanced case finding strategy, active case finding strategy, and intensive case finding strategy. Enhanced case finding strategy is basically what the passive case finding strategy is. It is an inbuilt of it, where there is awareness in the community and community members self-reporting about TB symptoms to the health system. Then what we have, other one is known as active case finding strategy, where a cross-sectional survey is done, going to house, make them understand about tuberculosis, and then find on refer and do sputum collection and transportation for any TB symptomatic. This is usually done in marginalized and vulnerable areas of the of populations, basically in remote and inaccessible areas, as well as with people living in slums and tribal population as well. Then what we have is ICF, what is known as intensified case finding strategy. This has been recently advocated and propagated by WHO in 3I strategies. What we actually do is a cohort who is followed up over a period of time, who is having TB symptomatics. Any TB symptomatic within that cohort is referred immediately to the system for his sputum examination and X-rays. So mostly it is done around PLHIV people, mostly for them, and then we have this prison, because it's a captive population, and then we have mine and others. So what we are doing is, we have this Global Fund Round 9 project, which is known as Project Akshay, which has been implemented in about 374 districts. And for implementation, we have PRs, principal recipients, and SRs as sub-recipients. So as PRs, it's a central TB division. We work with the collaboration with the government of India, and then the union, which is the organization from where I come from. Then we have World Vision India. So the union, as we are implementing this project in about 300 districts of this country, from out of 640, now it is 780 something plus. Then what is, with an objective of increasing reach, visibility, and improve the access and of RNTCP program in the society, and also to engage marginalized and vulnerable population and talk to them about TB care and control. So this is a geographical, this is a map that shows our presence across the country. We are almost covering the entire country here, you can say, with few common states with the World Vision India as well. We have left off about Gujarat and Himachal Pradesh and few other states. These districts were given us from the Central TB Division based on their RNTCP quarterly performance reports. We have about, this is our organization structure, and let me go to the directly to the ACF. What we did was, our objective was to conduct active case finding, is to go to house in an identified area and talk to them about tuberculosis, talk to them about RNTCP services, and identify TB symptomatic. We have taken the gold standard of cough more than 2 weeks as prime, and then weight loss and night sweating and other characteristics as additionals. And then provide information about TB care and control. We had IEC materials and everything, which we introduced to our volunteers, and we would go and give it to them. Then following that, we selected the Agra slum, which is one of the most, it's just a purposeful, we did not do any sampling or anything. We wanted to understand how this could be done. So we selected Agra slum, which is about, slum population is about 5,33,000, the figures are there. And this is from the census, and about 87,000 households were there in the slum. Basically, this is distributed across the district, but we selected very few hamlets where we found that in this consultation with DTO and everybody, where we found this thing. So this is a community volunteer. We have selected, what we did, we selected local NGOs. We were working in that area. We are also implementing other programs like immunization, family planning, and things like that. We selected those NGOs who had an experience in health and had volunteers and presence in the field. We educated them, we trained them about how they should, about tuberculosis, then about tuberculosis care and control, identifying symptoms, how should they go about talk to people in the households and things like that. So in the next, this one is about our volunteer here and our supervisor here, who is actually talking to people over there in the urban slum about tuberculosis. Then she's having some messages which she is going, which she usually gives to the people. Then what we have, this is what we also discussed with the public health system, the medical officers. People who are in India are well aware of the, if they are aware of tuberculosis program, we have a DTO, who is a district officer who leads the TB program in the district. Then we have medical officer, tuberculosis centers, which is established across the country, along with the, which is part of the public health system in itself. Then we have STS, which is supervisors and lab supervisors, as well as the program supervisors, who are the who are basically supervisors for all the lab technicians as well as for the program. So what we did was, we trained community volunteers. We call them as Akshay Mitras. Then we capacity build them about TB related messages, identified into how to identify TB symptomatics and things. Referral, when to refer and whom to refer to the nearest DMCs, which is known as designated microscopic centers. And from there, they have to actually go to the, if the patient is not, if the TB symptomatic is not able to go to the nearest DMC, his or her sputum is to be collected. For the, basically we educate them to collect the sputum in the early morning, rather than the spot sample, which we ask them to ask the TB symptomatic to go himself to the facility. Then we volunteer transported the sputum, as well as followed up on the referrals to the nearest DMC where they have referred. Then most of the time volunteer had to accompany the TB symptomatic whomever they have referred. Then they were sent to the DMCs where the sputum examination is to be done and the results were given to the volunteer. So this is a cycle what we did for the active case finding. About results, we had about 24 slums we visited in hamlets, and about 3,940 households were reached. From this entire households, what we found, most of the population were with illiterates and less than 10 years of schooling. So many were labor population. The slums which we chose were basically having the people who were cobblers, who were working for the multinational companies and others, because they used to get spare parts. There used to be a one-room facility for the cobblers in the entire place. So mostly were laborers, and then and daily wages basically. Then when we asked about their health seeking behavior, we have a small questionnaire which we had introduced. Where do you go when you actually fall sick? Many of them told they go to the private practitioners. The private practitioners are basically whom we are talking here are what we call as less than fully qualified, or what you call as rural healthcare practitioners, or what you call as quacks, what we call who has never been gone into the graduation schools like you and me or others. So they just have been transferred the knowledge over a period of time, and these are the people who are actually at the community, at the slums, who are providing them with care. So most of the, from 90%, almost 90% of this 91% people go to them as the first point of contact. Public health facility, we asked them a couple of reasons why do they don't go to the public health facility. They say it's a long queue, and most of the time the doctor will be not there, and whether if he sees also, he will say, yeah, aapko kuch nahi hai, means you don't have any illness, you are just coughing, it must be flu and something like that. He gives them some paracetamol and sends them away. So this was the reason. Then what we have is whenever they fall sick, what is their type of expenditure pattern? We try to capture that. Mostly zero, because RHCPs, usually they were not able to equate the kind in terms of monetary. So mostly with the RHCPs is in the kind. So that's why it is zero here. Otherwise, wherever they had paid a lot of money. Then when you distribute this with their occupation, you can see that laborers have paid about 55,000 per month on any illness, last illness they had basically. So next, going to knowledge about tuberculosis, which is our key focus area, where everybody heard about tuberculosis. They know it by name of SHA, which is a term which is used by the local people here. Then people told more than 2 weeks of cough. Yes, we know that 2 weeks of cough. Cough is basically the symptom for tuberculosis. That they were very well aware of. Then is TB curable? Most of them told yes, and some were 50-50, because when they go to these rural care practitioners, they usually don't tell them that they have TB, but they usually tell them, yeah, you have having cough, so you just take this medicine and it will be cured. So that was another thing. About 17 people within the population in their families had tuberculosis. So then about 8 were, from the family, they were able to refer us about 8 members of the family as TB symptomatic. Then when you say about from the 17 people, 17 households had TB patients, from there we had 4 members of the households were able to give us the full information, complete information about their expenditure pattern. In that, what we found, if you can see here, about payment to the doctor is about 3,600 rupees. I don't know how much it will come divided by 62 in terms of US dollars. Then you can actually see about, for medicines, they have spent a lot of money on medicines. Basically, when the medicines are free of available in the RNC program. Then we have the results of ACF. When we have referred about, our volunteers were able to identify and refer about 400 TB symptomatics. Out of them, we had about 7 positive, and all 7 were put on dots. The major challenge what we found was about the stigma. There was in the slum areas, there were one slum area which was very near to the TB hospital. And when we referred most of the people there, they were not willing to go there, saying that that is TB hospital and we don't want to go there. Whomever we referred as TB symptomatic, many went to our RHCP. So we went and talked to the rural healthcare providers or quacks or people like that. We went and talked to them. They told, they were telling us that yes, we were getting those patients who were referred through your volunteers, but we don't actually encourage them going to the public health facility. That was another thing. Then when we also look into on the other side of it, why it is low positivity rate. It depends on how our lab technicians are trained. When you are talking about multi-skilling, task shifting and things like that, the tuberculosis program has been vertical since very long. So it has actually trained LTs, and over a period of time they have gained their knowledge. So it's not so easy for many of the people to actually do a sputum examination. So an LT trained in RNC program for the sputum examination, he has to go through vigorous training, because all this, we have EQAs and things like that which LT has to go through. So that is one of the key challenges what we found. But low positivity rate was because TB symptomatics, whomever we are referring, were all sent around roundabout, so they were not actually going to the facility itself. Health system staff, though they were in acceptance with us that yeah, something like that should be done, but when they started seeing 400 people on a 10 days 20 days period, they were all wondering that their carbamazepine solution will get exhausted, because they were already on depth with the agency for supplying carbamazepine for taking this thing. Secondly, they also expressed the difficulty if you bring us for 20 people 30 people standing here in queue for me to give them medicines. It's not possible, because according to my target, I have already covered my target, which is 75 per lakh population. 50% of that he has to achieve, he has achieved. But under the UHC, Universal Healthcare Program, and another National Strategic Plan, which has recently been implemented across from National Strategic Plan 2012-2017, which says under Universal Healthcare Program there is no target such like any TB patient or TB symptomatic, whoever comes found to be TB positive, has to be put on dots. So, but this was actually not there in anywhere near the district TB officers or MOTC. Thank you very much. I can take up further questions. I would like to acknowledge some of the people here.
Prasad, you've got one more presentation, right? But you don't have much time. So can you just focus on the objectives and conclusions in your second presentation and do it in 5 minutes?
Yes, that I can do it.
Okay, sir. Why don't you do that first?
So based on this active case finding, what we did was we picked up a component of sputum collection and transportation for tuberculosis control in 2 states, Meghalaya and Mizoram, where we are working. So this is all our public health facilities, how is established. We had, my colleague and myself, we had presented in last conference out here. Then, which is basically a modified form of ACF, where we actually educate people about tuberculosis, identify referring TB symptomatics, sputum collection and transportation. So we mapped about facilities, vulnerable and population. Basically, if you take entire districts are vulnerable and marginal population. But we picked up only those places which are not actually getting connected with the local transport and things like that. So what we did, we identified volunteers, mainly the church is very strong in those areas, so mainly the church volunteers who are actually working. We educated, trained them about tuberculosis and gave them IEC materials, informed them how they should go to the households and what they have to do. Then we also established sputum collection and transportation centers and volunteers them most of the time. I'll just get back to that. So how we did was what we termed the same intervention, active case finding. What we added here were nomenclatured it as Akshaya Samvad. Samvad is basically a discussion between people about tuberculosis. So that's what we did. Then what we did was we had this transportation mode of volunteers. The volunteers were actually, we were paying about very low incentive, about 40 rupees for them to transfer one TB symptomatic sputum. But what was happening was we then established sputum collection and transportation centers at various places so that they can.
Can you just conclude, because you've over exceeded your time.
Okay.
Thanks.
I'll just finish off with this slide. We had about 764 sputum collection and transportation done. About 78 were positive. And basically the health system, we actually strengthening the public health system for the RNDC program in case detection rate. I think I will stop at this. Thanks.
So we have about a few minutes for questions. So we'll take questions on Prasad's presentation. The gentleman.
Hello, I do have one question. So you study about the tuberculosis in the mainly of the slum area, right? So those people are very much poorer. So they went to the pharmacist and they show them as they have a fever. So when they consumes the ciprofloxacin or fluoroquinolone drug, it suppresses the tuberculosis for a few years, right? So can it have a major role for the delayed disease diagnosis and the emergence of MDR and XDR? Have you found those sort of cases in your study?
Yeah, thank you for the question. Actually, we are actually going, it's a very challenging thing what we are doing there. Basically, when we refer this patient, they go to the RHCP. Like you told, they are being given higher level of antibiotics and things like that. So we have another component within this project. What we are going to do is we are sensitizing the rural healthcare practitioners as well as the private practitioners, where we are telling them if you have any TB symptomatic, please refer them, or please follow your own regime, but please follow your WHO regime, not the own regime, like so that we can contain MDR TB and XDR TB, all those things. Thanks.
Other questions? There's one there. Oh, it was 1 second. Yeah.
Thank you very much. As a veterinarian, I was wondering whether your patients had any contact with animals, cattle, for instance, and whether bovine tuberculosis could be suspected in your patients, and whether it is checked in the lab on your samples, whether it is Mycobacterium bovis or Mycobacterium tuberculosis. Thank you.
Yeah, when the people whom we referred were basically just symptomatics, and when we did the sputum collection and transportation to the labs, the only thing what they recorded, if it was saliva, they used to discard. Mucoplurin samples they used to examine. And about your other question, sorry, it was about
whether people in the slums have close contact with animals and cattle, for instance, or milk products.
Okay. No, that we did not find, because it was completely slum population, and there was complete congestion with the people. No, that was not there.
Okay, I think because we are running short, we are trying to keep time. Save your questions for him later on. We'll move on to the next speaker. So, big hand for Prasad. The next speaker is A.M. Guru Prasad. He's going to be speaking on community-level monitoring control of lymphedema using self-care and integrative management. Mr. Guru Prasad is a postgraduate in Ayurveda, and he heads the Ayurvedic department in the Institute of Applied Dermatology.
Thank you. Good morning. Now I'm going to talk about community level morbidity control of lymphatic filariasis using self-care Ayurveda and yoga therapy in 2 endemic districts of South India. So the lymphatic filariasis is second cause of disability and affects around 2.5% of Indian population. And we developed an integrative treatment protocol combining Ayurveda, allopathy and yoga and traditional medicine, and published in Lymphology in 2007, and our institute was considered as world's leading lymphedema clinic according to WHO. Based on this presentation is the community implementation of the same treatment protocol in 2 districts. The study design was controlled before and after study and non-randomized community-based trial. And this study was done in August 2010 to April 2012. And it was approved by the Institutional Ethics Committee of IAD. And this study was funded by CCRS, Department of Ayush. The study setting was Gulbarga of Karnataka, which is very dry land. Around the annual rainfall of around 777 mm, and another setting was Alleppey, which has 82 kilometers of coastal area and has canals like that. And the program was monitored through telemedicine, and continuous monitoring was done between 2 centers with the IAD, and this complete program was monitored by National Ayurveda Research Institute for Vector-Borne Disease, Vijayawada. And there were 4 stages. One is survey, camp, third one is workshop, and fourth follow-up. And the phase 1 includes rapid survey. We used ASHA workers, treated patients, NGO, CBO, Ayush doctors and modern doctors to collect the secondary prevalence data about the patient. The phase 2 includes LF camps to recruit the patient for the third workshop, and we also educated the patients, demonstrated the skin wash, demonstrated the simple yoga exercises. We arranged 25 camps in Alleppey and 27 camps in Gulbarga, and we recruited patients for next phase, that is workshop. The inclusion criteria for our study was grade 2 late lymphedema and grade 3 lymphedema. And we excluded the acute inflammatory episodes, the patients with acute inflammatory episodes and who has complicated limb like ulcers, chronic eczema, and our integrated management include Ayurveda, allopathy, physiotherapy, and the method of administration, we had 7 steps of intervention, and administration is OP-based supervised treatment for 14 days, and we also trained at least one member of the family, and we followed up the patient at every month for 3 months. Our interventions, our steps include the skin wash with the lukewarm water. We advise to use same brand of soap. And there is next step includes Fanta soaking. Fanta is herbalized solution. We used 4 types of Fanta, means herbal, single herb to soak, and advised to soak for 20 minutes. Actually, this has wound healing property. And yoga exercises. That yoga protocol contains 13 asanas and 5 pranayamas. Pranayama means breathing exercises. And we had protocol had 2 sessions, that is pre-IMLD yoga, that is without compression, and post-IMLD yoga with compression. And after yoga exercises, pre-IMLD yoga, there is a Indian manual lymph drainage, that massage without oil. Then after part 1, part 2, that is massage with oil. So oil will be selected based on the condition of the that limb. And after IMLD, there is a compression therapy using long stretch bandages. And our outcome measures of our program include quality of life using LF specific QOL questionnaire, girth measurement using tape, limb volume by water displacement method, inflammatory episodes, bacteria entry points, and photographic evidences. And data were analyzed through parity test, linear regression analysis, and McNamara test. This is the flowchart of the flow of patients to different steps of our this one. We treated 1,008 patients, and we had a follow-up of 730 patients with a 73%. And we treated the patients, 83.8% of patients with the disease duration of about 10 years in Alleppey, and 65.2% in Gulbarga, and 58% of Alleppey had below poverty line. The quality, we had below 1%, below 0.1% level of quality of life changes after the treatment. The volume reduction from 10 liters to 7.7 liters within 3 months of treatment in Alleppey, whereas in Gulbarga 10.6 to 7.2 liters within 3 months of treatment. See, bacterial entry points from 83.1%, it was reduced to 59.9%. And there is a very significant reduction in inflammatory episode after the treatment. I will show you some photos. This is from Gulbarga, the reduction in edema after 3 months of treatment. This is also from Gulbarga. This is the changes of after treatment. This patient is from Alleppey. This patient is from Alleppey. This is also from Alleppey. This is after 3 months of treatment. This is from Gulbarga. This is also from Alleppey after 3 months of treatment. This patient is from Gulbarga, and this is also from Gulbarga. So we had a significant level of reduction in volume with very narrow confidence interval, that is 53.8 to 57.7 in both large and small limbs. And we have done the follow-up visits to see whether they are continuing the treatment in home. And we observed there is a gradual reduction of edema who is concordant, and there is a gradual increase in edema who is non-concordant to the treatment. And we observed that the patients rejoin their previous job after taking the treatment in both the centers. And the strengths of our this treatment program is, this is the first public health program using Ayush interventions. This is public-private partnership model, and we had successful collaboration with the government setup. That means ASHAs and DMO and non-governmental organizations and CBOs, and we recruited and trained the local persons to deliver the treatment for the patients, and we used locally available materials for treatment delivery. And as Professor Witte said in her editorial in lymphology, the treatment protocol fit for both the institutional and remote villages. And this treatment was published in Transactions of Royal Society of Tropical Medicine recently, and it was considered as low-cost public health intervention for lymphatic filariasis using self-care, Ayurveda and yoga. And I acknowledge my gratitude to Central Council for Research in Ayurvedic Medicine and our mentor, Professor Terence J. Ryan, Oxford University. Thank you.
Thank you, Guru Prasad, for a very interesting presentation. We're now open for 5 minutes of questions, so please raise your hands. Okay, quickly, then the next.
See, lymphatic filariasis, now the global program for elimination of lymphatic filariasis is going on.
Yeah.
When your studies recruit the lymphedema patients, are you given any incentive to them to come regularly to your hospitals for practicing your treatment?
No, we have not given any incentives.
Actually, in Tamil Nadu government, under the disability care,
Please keep, can I just ask the question, because there are other people waiting also.
This one. Another thing you were telling the panda or something, is it available in the commercial market to the patients to go and buy?
It's a single herb. There are 4 types. One is Glycyrrhiza glabra, St. Madhu we are calling in Sanskrit. And another one is Sariva. Sariva means Hemidesmus indicus. It's a single herb. And it has, depending on the local skin pathology, we are giving that single herbalized liquid. And we are just powdering and we are using...
It's not available in the commercial.
No, it's available. It's a raw drug. It's available as a raw drug. We can just powder it and give it. That's all.
Okay, thanks.
Second question.
Okay, of course your photos are very impressive. I think everybody was quite impressed with that. But of course, my first question was, is there no treatment available in the general community before you started with your program that people with such lymphedema can attend to? First question. The second one is, how low cost is low cost?
I didn't get...
You didn't get what, the first or the second?
Can you just repeat your question again? So he'll...
Okay. When you showed your photographs of the results of your treatment, these are very impressive. Yes? The reduction is impressive. But what is also impressive is how big the lesions were or how big the limbs were before you started. The question is, do these people not have any access to effective, what's it called, lymphedema treatment outside your program? And the second question is, how low cost is low cost?
Actually, institutionalized, that was discussed in our paper, that institutionalized the care costs around 20,000 rupees for the patient for initial 14 days care. But by recruiting these collaboration with the government health sector, that cost will reduce. That is our intention.
How much does it cost?
Actually, the compression bandages are the most expensive part of our this one. So it costs 1 meter bandage will cost around 400 rupees, and each limb needs around 8 to 10 that bandages. So it around 8,000 rupees we are calculating for per patients.
Okay.
Which is not that cheap.
Yeah, it's not that
That was
much
the first
cheap.
question also asked. Perhaps these people have undergone other treatment as well, next to your treatment. How can you rule that out?
No.
In these impressive improvements, perhaps it's also because they used...
No, there is. This
Was not the case.
no.
Okay. Any more questions? One last question.
Getting smaller, but is there any chance to get it bigger after the treatment? Do you have any follow-up on that?
Yeah, the patients who were non-concurrent for the treatment, we observed there is an increase in not increase, the same, the amount of swelling was observed. There is no reduction. There was no reduction observed after 3 months also.
No.
May I?
Yeah.
I think the question was, for instance, 1 year after.
Yeah,
After
it's,
having-
it's
does
just completed 1 year, means last April it was stopped, means concluded this one, not 1 year.
No, so the question was, after their treatment, was there recurrence of the original condition?
Those who were non-concurrent, we observed the same amount of swelling was, there's no reduction, who were non-concurrent.
All right. Thank you.
So I have a question. Last question.
Yeah. So now we move on to Parishod Malavia. He's going to be speaking on the role of village health workers in control of visceral leishmaniasis in Bihar. Paritosh is the head of the data management unit at the Department of Medicine in Banaras Hindu University.
Hello and good morning to everybody. Now I'm going to present the role of village health workers for the fight against the visceral leishmaniasis in Bihar, in India. As we already have discussed so much about this, the visceral leishmaniasis is a major health problem, especially in the Bihar state of India, which constituted more than 50% of the caseload of Indian subcontinent. And in Bihar, Muzaffarpur has the highest caseload. Visceral leishmaniasis is considered as a disease of village, a rural disease, and disease of the poorest of the poor. In 2009, we conducted a random survey among 150 randomly sampled patients of visceral leishmaniasis who were treated by 14 PSCs of Muzaffarpur districts in 2008, and along with them we also interviewed their concerned physicians. And during this survey, we identified several shortcomings of these VL control programs. The major one was that there were no adequate reporting of the treatment outcome at the end of the treatment, and there were no follow-up of these systems. We found that 28% of the VL patients were not cured, but this information was gone unnoticed by the PSA staffs, and they were not aware that this actually happened. And in their record, all the patients were assumed to be cured at the end of the treatment. So what was the solution? How can we get the accurate reporting of the treatment outcome at the end? One solution was we can go for this kind of random survey on frequent basis, on periodic basis, but whether it is feasible or not feasible. And if it is not feasible, the second option could be the involvement of the village health workers such as ASHAs or ANMs in our systems. So we tested for the feasibility of our random surveys in the periodic manner, and we observed that this is really very time consuming, costly affair, and labor intensive. For getting interviewed 150 patients, we had to visit more than 210 visits, and for this we traveled around 5,280 kilometers. And the cost for interviewing per patient was above $15. So it was a really very costly and labor-intensive work. So the alternative was to involve these village health workers, especially the ASHAs and the ANMs. ASHAs are actually village volunteers. They are married women, young women in the community itself. They are volunteer, work for incentives, and they provide their services on incentive basis in several programs of the government, such as immunization, maternal and child health, institutional delivery, and they also work as a dot providers. In our healthcare systems, we have three levels: sub-centers, primary health centers, and community health centers. And at the grassroots level, these two village health workers lies, the ASHAs and the ANMs. And some of the programs has identified their contribution, their important contribution for the implementation of the program, and especially the tuberculosis program, which identified them as a referral agent as well as a dot provider. And the treatment outcome of this tuberculosis control program largely depends on the outcome provided by these two health workers. But whether they were willing to be a part of this VL control program or not. For that, we did a CAPS survey among randomly sampled auxiliary nurse midwives and ASAs from the Muzaffarpur districts. We obtained a list of all the active ANMs and ASAs from the Muzaffarpur district headquarters, and we sampled randomly 100 ANMs and 100 ASAs. We interviewed them at their workplace or either at their home, and based on a structured questionnaire comprising of the questions related with their knowledge, training, experience, knowledge and information about the VL as well as the tuberculosis and their experience with the tuberculosis programs, and whether they were willing to participate, to get involved in the VL control program or not. So it's a picture of interviewing ASHA, one of the ASHAs. The results was that medium experience of working with this system for the ANMs was 19 years and 6 years for ASHAs. And this shows a good retention in the systems by these two workers. In the last 5 years, they had referred us at least one suspected cases to the PSC, suspected cases of the VL to the PSCs. And still, there were some cases in their catchment area, but their involvement with the VL control program was almost negligible. Regarding the signs and symptoms, the transmission mode, the diagnostic, and the procedure for diagnostics, they had a good amount of knowledge. They know that this is febrile, the main sign and symptom is the fever, prolonged fever, and it is a vector-borne disease. But regarding the treatment of the leishmania, the knowledge was really very poor. But one good thing that they knew that the free treatment is available at the PSCs. Regarding the willingness of the participation in the VL control programs, we observed that almost everybody of them was ready and was eager to get more involved in the VL control programs. They were ready to pay at least one visit on weekly basis, and mostly by the ASHAs. Since ASHAs are working as a volunteer and they get incentive for their services, they were asking for some good incentives, which was around between 500, 200, 1,000 Indian rupees. And for this, since they get government service, they were not exactly willingness to get some incentive. They wanted to have some kind of supervision work. So based on these findings, we concluded that these village health workers should get involved urgently on the VL control programs. It has additional advantage of active case detection. They can work as a dot provider because miltefosine is now an oral drug and which can be given at the home itself under the direct observation of these ASHAs or ANMs. And since ASHAs are well organized, they have a direct link and connection with the PSCs, and they visit PSCs at least once in a week. So they can get information regarding the patients, and they can collect the drug from the PSC itself and give drugs to the patients at their homes. And they can also report the treatment outcome at the end of the 28 days of the treatments. So our recommendation was that it's urgent need to get the involvement of these two health workers. I acknowledge my team, our supervisors and social scientists who conducted all these interviews and the fund given to us by the NIH TMRC grant. Thank you very much.
Thank you, Paritosh. Questions for Paritosh's presentation? Yep.
Thank you. I would like to ask a question pertaining to the work of the ANMs and the ASHAs. ANMs, the accredited nurse and midwives, yes, and the ASHAs are the social health activists. In your experience, how many diseases how many programs do they have to manage? Because this is about visual leishmaniasis, but I'm sure there are other things they have to do. Could you expand on it? How many other programs are looking at these people to be involved in control?
Yes, so we have several vertical programs and other programs running in the Bihar states, and at the grassroots level, the implementation of all these programs actually comes in the court of these two, especially the ANMs and ASAs. We also conducted a workload assessment regarding, because our study was just for visceral leishmaniasis, and we found that at that time in 2012, the incident was 30 per 10,000 of populations, and the catchment area of the ASHAs are just around 1,000 population. So for each year, one ASHA has to deal only 3 cases, and this is not that much additional workload. So,
next to visual leishmaniasis, what other diseases, what other programs do these ASHAs have also to run? The same ASHAs?
Yes, like tuberculosis control programs, they work for polio immunization and for maternal and child care, institutional delivery, and for all these things they provide, they are given incentives.
Okay. Question at the back, and then.
Okay, thank you for the presentation. Now I think you started out with the statement that 28% of the people in your survey were not cured.
Yes.
And that the primary healthcare staff were not aware of that, and that therefore there was a problem of monitoring in the system. Yes? Yeah. Now, what do you expect of your community health workers or village health workers? Is this to improve the monitoring, or is it to give support to the patients for their treatment?
Actually, in the leishmania is such kind of disease where after the complete doses, the patient needs to go back to the hospital and report their current status of the health. But this normally does not happen in the ground, in the reality. And patient never reappear again before the physicians. So that's why, based on the number of the doses or the pills taken by the patients, it is actually assumed that the patient has completed his 28 days of multifocal treatment, and it automatically assumed that it is the patient has been cured because patient not returned back to the PSC. So we thought the urgent need is to report the treatment outcome. And in addition, they can support for the treatment adherence also. But the important point was the monitoring and the reporting of the outcome at the end.
Yeah, thank you for the interesting presentation, because what we found during our interaction with ASHAs and ANMs, that RCH program used to take the first priority, then the disease control programs. within the disease control programs, your NVP-DCP program takes the first priority, like malaria control, all those things. So the least was tuberculosis. So I would like to understand from you, how was it challenging for them to motivate for disease control program, basically in your case, and how did you go about doing it? Thank you.
Challenging in which term? Implementation of involving of the ASHAs?
Yeah, how did they prioritize your intervention? Because for them, RCH is the first.
I'm not able to say anything on this platform, but they have lots of responsibilities. ASAs, especially, they have to contribute several programs running by the governments, and their priorities are already fixed there. In addition, we are advocating an additional workload for the leishmania control. It would be challenging in some areas, but areas like Bihar, where the leishmania is a major health problem, this should also be included.
Okay, one last question and then we'll move on.
Thank you for presentation. Myself, Dr. Rathore, working as a district epidemiologist in Rajasthan. Do you have some incentive for ASHA for giving treatment and supporting in your intervention in your state?
Recently, the Bihar government has issued a circular that for the first confirmed suspected cases, for first confirmed cases of year, they will get 500 rupees as incentives.
Because as in malaria and RNTCP and leprosy, they are having some kind of incentive, because government is not paying them any kind of the salary. They only work if you are giving them some incentive. Otherwise, why do they will work?
No, but in case of leishmania, it has been circulated.
No, this is just being started, or that was started when you had your intervention?
Recently started.
Okay, thank you.
Recently started. We had a circular of 2012.
Okay, Rupa, do you want to end the discussion session?
Yeah. No, I think this brings very clearly to light the mindset of what is public. I mean, your question, sir, about why would ASHAs work without incentives? I mean, this is central to the whole debate of what is important, what do we consider ours, what is communities, and where do we draw these lines? Yeah? Are the ASHAs paid, Paritosh? Are they paid at all? Do you know?
They work, they get incentive per service basis.
Okay. I mean, this is a personal observation of 25 years in working with communities, and a lot of literature that often these women come in with ideas of working for their community, being empowered, doing a lot of interfacing with the health sector, and somewhere along the way they get sort of channelized into becoming the end point of the health service. Now, this is a very central debate in understanding the crucial interface between the community and the health services. And what is her role? So when we talk on one side of local stewardship, what is the power equation between this woman? She's a woman, mind you. Huh? She's a woman. She's at the bottom rung of the social ladder. And then she has to implement this. And then we talk about integration sitting here. I don't know. For me, it throws up a whole series of questions. Where do we place ourselves in this debate? Sorry.
Good. Maybe we can try and find answers to those in the discussion section. So now it's my pleasure to invite our last keynote speaker, Professor Veera Satki from Songkhla University, Prince of Songkhla University in Thailand.
Before I start, I would like to tell you about what is Thailand health system history, and we have 60 to 70 years infrastructure development in health systems, create several primary health care in the village levels, and in the last 2-3 decades. We have to thank ITMs in contribution with the training of several our doctor leaders, not only training but interact very actively, set up a healthcare reform office in Ministry of Health, which eventually lead to not only strengthening of the health infrastructures, but also Thailand become the forerunners of the universal coverage 10 years ago. So within this context of universal coverage, the neglected tropical disease is included free of in the service, diagnostic, screening, everything free of charge. And Thailand recently, last couple of years, have been nominated as a country with good health at low cost in the past and currently in the reform process. The second country that I work in the health system related to disease control is China. China got a different history. It got a revolution in 1950s, followed by successful controls of neglected disease, schistosomiasis, and a lot of infectious disease. In the 60s, it has created the grassroots health workers, barefoot doctors, which Thailand went to the study tour, and later Thailand adopt this system but modify into village health volunteers, which not giving treatment but more on the health promotion and preventions. In the 80s, China got economic reforms and neglected all the fundamental health services. All the health services become out of pocket in payments. So at that time, I got involved, and in the late 90s and 2000s, I got a lot of students both from China and Thailand, which I try to get out of some of their research for this presentation. In general, we got the priority shifting in countries where we have demographic transition, ethnic transition, and socio-economic new concept that we want to get more equitable health systems. I borrow a slide from Dr. Bruno's, which is from WHO. Instead of covering everything, I just want to focus our study on the first is the effect of universal coverage on disease controls. So Bruno has the health system as an outcome, strengthening as an outcome. My presentation will be health system as an exposure that affects the disease controls. Apart from health system, I would like to remind that without good research, understandings in the natures of the disease transmission, we don't know how to start. Whatever you do, vertical or horizontal program, it won't work. I will show 2 cases of vector-borne disease in Thailand, which we completely fail. And finally, I will discuss about health resources, human resources on health management, which affected by the healthcare reforms. First is the universal coverage is effective, is important to have effective disease controls. And this is the study case in China. In China, they started universal health coverage by so-called NRCMS, New Rural Development, New Rural Communities Health Insurance, which cover 90% of the population. But it's very shallow. So a lot of health expenditure is still in the out-of-pocket. We conduct a study in the Yunnan province in 2009 and look at one of the factors with in endemic areas of endemic fevers, 714 cases out and inpatient from 6 county hospitals were reviewed in the records. Those must have at least 3 days of high temperatures. So we see how people get hemoculture in their diagnosis. This is typhoid suspect, and you can see that Q4 is the upper quartile of the incomes. All of them got hemoculture, whereas Q1, that is the lower quartiles, only 10% of the patient got hemoculture. So the system in China at that time, nowadays it should be improved. We got a lot of problem with out-of-pocket payment that become the barrier for correct diagnosis of this neglected disease, which also lead to poor surveillance systems. So financial barrier is important. I think we should try to publish more papers to convince the governments that without good financial support, eventually the neglected disease cannot be properly controlled. You cannot have just vertical program, because a lot of neglected disease don't have vertical program, but depend on the accessibility to routine care and the quality of care, which you have to strengthen the health system as such. The second part of my argument is we need better science and technologies. I illustrate the dengue infection and chikungunya. Dengue infection is well-known nature on vectors, and we have in Thailand we got a lot of cases, but we have this 3% is not from Thailand. Thailand is got less than 1 in 1,000 case fatality rate, but it's a lot of burden to the healthcare. So the community program is the poor and non-sustainable. We cannot demonstrate any sustainable success in most of the Asian countries. I think we have to look from example from Cuba. So vaccines, Thailand just finished the vaccine trials after 20 years of attempt supported by WHO, and it's completely failed. So we have to start. The next human trial will be next 10 years. So we are quite hopeless. And spray may not be so effective in interruption of transmissions. Nowadays, the spray program is in the hands of, we completely centralized. It's become the duties of the municipalities, health sectors. It's not the Minister of Health anymore. But anyway, we conduct a study to see how effective is Epnico. This is the first index case in green spot here in the middle of the slide. Maybe it's okay, it's here. Then this is in the end of January 2007. By the recommendation of WHO, we have to spray with a radius of 100 meters, covering all households. The pink one is the target for the spray. So actually, the spray is run by local public health people. They just spray along the street, and you can say that even within the street, in the narrow strip, there's still a lot of houses not covering by the spray. So within 1 month, we got secondary cases in those areas with increased spray and spray. So we use this kind of GIS analysis in the whole municipality area to see whether spray has any impact on interruption of the secondary cases. And this is from Poisson regression. IDR come from incidence density ratio, because we look at the blocks and try to see the incidence of secondary attack. We see that out of these several p-values here, only one variable got significant. That is the nature of the index house. If the index persons live in a house created by corrugated iron sheet, which is very poor, then it's more likely that their neighbor will have secondary infections. But the spray per se, you see, regardless of your spray, regardless of the spray, there's no impact on the secondary incident. So by this conclusion, I think more important is the housings rather than the spray. So, but how to improve the housing it's out of health. So I think it's very good to say that health in all, right? Health in all. So in the construction, in the municipality planning and everything in housing, we have to incorporate the disease control in the planning. So this is the third examples of health system response to chikungunya. Chikungunya is a welfare virus transmitted by the Aedes, both kind of Aedes aegypti, but probably more important is Aedes albopictus, which is the outdoor biting. So it's re-emerged at epidemic in Africa and Asia along the Indian Oceans in the late 2000s. The attack rate is very high and create a lot of economic impacts. Even in the health systems, a lot of surgeons cannot work because they cannot move their hands. It's very painful for a couple of weeks. And it's non-stoppable. It eventually is went out by the nature of probably by the nature of herd immunities. I just want to say that we don't have any technology to respond. Regardless of your vertical or horizontal program, it's useless. So we need more research. This is an example of the burden of case compared between dengue and chikungunya in the outbreak. In the outbreak years, there's almost 15 times more important for chikungunya. And you can see from this graph that the disease spread from the left-hand corners is in the first month of the year. Then it's gradually spread along the peninsulas up to cover all the peninsulas. So it's completely non-stoppable. So in conclusion, we cannot do anything with this vector-borne disease for several decades. And we need more research, applicals or technological research to counteract, regardless of your healthcare reform or in vectors or whatever you do. That is all inadequate. My final case study is the human resource competitions. In the transit of universal coverage, the levels of health services can be dramatically increased. Sometimes, usually we expand from 70%. You cannot starting with zero coverage to 100. The good point to cover to blow the whistle to have the universal coverage is about when you got public health insurance by different scheme by 70%. And then you say, okay, now everything is free. And the experience in many countries is once you announce that healthcare cost is free, the caseload in the hospital and the health centers can be double suddenly with the same numbers of health service personnel. So a lot of service load. And then the service load, the government has to respond by increase more incentive for the healthcare providers. And this has the impact on the health service, on the disease control personnel. And we expect that with integrated health services, we should have one-stop service so people don't have to go here and there several places. They just come to one place and get whatever from the patient's perspective, whatever disease they got, either degraded or non-disease or cancer, they should just come to one place. But that is cannot be always ensured as the following data. So the examples in Thailand is we lost a lot of DOTS coordinators from Thailand has no vertical program. but the personnel is delegated to do TBs in some of the province. But after the healthcare reform, after universal coverage, there's a lot of needs to administrative purpose. So it's the Ministry of Health said that, okay, we cannot keep WHO standard, one coordinator for 700,000 population. We have to increase to 1 million. That diluted the effort in the dots. And the impact on the health system delays. In fact, we test the models and do the survey on the delays. Health insurance, whether you have or not have, or whether what type of insurance, has no effects on the patient and health system delay for TB whatsoever. But health system delay was prolonged among UC patients, presenting themselves to the lower level care levels, like in the health centers. If they go to the specialized care, they get quick diagnosis. But if they go to the referral system set up by the system under UC, under universal coverage, that you cannot bypass, then it further delays the diagnosis and treatment of TBs. So finally, we look at the dynamics of health personnel. So this is the median time to get trainings of new staff in TB clinic. In Thailand, we have TB clinic integrated into every community hospitals. So they run this clinic maybe once every fortnight, or up to once every week, or once every month. So these are trained people. They know how to trace, how to do the dots, and how to do the cohort analysis, and monitor cure rate, etc. But they have to do this. They have to be trained. So this is we usually recruit from the other sectors, and we have to give them some trainings. The white Kaplan-Meier curve is before health system reform, and the yellow is after health system reforms. And this is a comparison of the medians. Before health system reform, usually when you move, you get very quick trainings. So by less than 1 month, 50% of the personnel who are recruited are trained. Compared to after reform, you need almost 5 months, and the hazard ratio is 0.67. That means the chance of getting training in each moment is reduced by 1/3. We look at people moving out from the service, TB service. Again, the white Kaplan-Meier line is retention in the TB service before health system reform, and the yellow one is after health system reform. We can retain at least 50% by about how many years? 3 years at least. We retain the expertise for that service for 3 years. But after the reform, we can retain them for less than 2 years, only 20 months. So this kind of this is the impact that I try to demonstrate to you, that and this is actually the attrition is 4 times as high in the hazard ratios. So conclusion from this evidence, we got inadequate knowledge to stop dengue and chikungunya fever spreadings, and that is very, very annoying. And universal coverage need to reduce financial barriers to endemic entities. I hope you can use this, try to find some evidence to support your speed up the universal coverage programs. And the health systems restructures have to be carefully monitored, because it may shift the human resource from disease control to serve general health services and weaken the system. And it may create complicated referral system, and it may speed up the turnover rate and delay training of the health system personnel. Thank you.
Okay, thank you. Professor, could you please still stand there and take questions? Any questions for, let's start with the lady in the back.
Good morning and thanks for a very good presentation. I am Amrita, Dr. Amrita Sarkar, and I am from Assam, Guwahati. I wanted to focus on this thing. You told that more needs to be done. I agree with that. More technical research needs to be done. More vaccines need to be developed. I agree. But then there are simple solutions also. I mean, in 1996 in Delhi, there was this dengue epidemic, and it was due to water accumulation from air coolers. So this is such a simple thing, it could have been prevented. But we didn't have, the community didn't have much knowledge about that they have to change the water. So can you do some simple things, interventions, like bring into school curriculum these things that we need to do this stuff? What is the importance of cleanliness? We know we are taught in school that cleanliness is next to godliness, but we are not told why. Why is sanitation important? I mean, can small things like this, subjects like prevention of these diseases, infectious diseases, importance of sanitation, importance of simple measures, can be taught in school curriculum, in lessons, can be included in lessons, that would be very effective. Because children are not only intelligent, they understand very well, and they have the capacity to persuade their parents.
Can you ask your question? So
Yeah.
Please.
Thank you.
I think the question is, can we simply ask and tell the people to reduce the breathing press? I think yes, but that's not effective. From empirical evidence, you can decrease the several indexes in the entomological index, but there's no long-term effect on the incidence of dengue. That's a bad news. You should keep on telling people not to produce breeding pests, but there's no evidence that can have sustainable effects on reduction of dengue incident.
Thank you. But
I'll come back to you later because everybody needs to get a chance. So, the gentleman in the front, you had a question earlier? Yeah.
Even in developed countries like Singapore are still facing the program in controlling the dengue and chikungunya, even by introducing the fine and all those things. In Thailand, are you initiating from the government level to introduce any kind of a penalty for the people who are breeding the mosquitoes inside their house? Like example, it is breeding in the defrost dry water collection in the refrigerator. The refrigerator, who will go and do it? It is basically a community, the households. Such kind of things, as the madam has told, it has to be comes in the curriculum, and the students has to take into the knowledge to their home. There are several papers from all Indonesia and Thailand. It is published in Dengue Bulletin, Asia, and it is being practicing, but it's not in fully effective. Is there any legislation, please?
No. No.
Okay.
Because I would be against, because there's no evidence. Yes, if somebody posts this into legislation, I would be against, because there's no evidence that this is effective control.
In 2007 and 2008, I was at least in South India, Jeddah municipality, to train the volunteers, student volunteers for dengue control program. There, what we did, people who are the laborers in the residence keep several kinds of traps and drums for water storages, Pakistani, Imanis, several people. In that, those things were removed by the municipality. They introduced a big drum for the domestic usages. Thereby, there was a lot of reduction in the yeast breeding. Such kind of practical things, measures.
Yeah, you can do anything, but there's no evidence of effectiveness. I think there's a certain evidence from Cuba that they can sustainably can contain, reduce the incidence rate of dengue for several decades. But we still have to see. And the nature of the vectors and the virus and the nature of participation of the people. For example, I talked with our colleague from Cuba. All people open their houses for spray, but in most of the country, I think including India, even you are very, very poor, you are not going to invite people to spray your bedroom. So it's quite desperate. By I show you in this evidence. So I think we still need more research, but have to have some fine breakthrough. But as a health advocates, we should say, okay, the evidence, for example, as housing. We got a lot of evidence on the housing as a risk factors, not only in this study, but other study that with good housing you can, like Singapore. Singapore has very good housing. But they got the policy to be the garden cities. With this garden city, they got attacked by chikungunya because you got albopictus. So there's no ultimate solution.
Question, the lady there.
Thank you for your interesting presentation. I particularly liked the documenting part on the TB personnel and the training. Now you looked at the effect of the reform on your TB program with regard to staff, but did you also look what the overall system gained? Was it a more balanced situation with regard to human resources and the overall capacity? What did you gain for other diseases? As you rightly said, there's many infectious diseases without program. Was it more balanced then for looking at the overall picture, not only at TB?
Unfortunately, there's no data on that. Might be, but I don't have those data.
In the back.
Thank you for the presentation. It's actually, when I see the last slide where the conclusion, I could understand that the health reform is not good for the patients, because there are patients that are suffering, because if they're using the system as it is, they will go to the complex referral as you explain it. And then also, it's not good for the healthcare providers, because they're losing the opportunity for the training, they're losing also their opportunity, and they are also, the turnover is more after the reform. And the third one also, which is not good, also for the effect for the programs, which you give an example in two ones, that the one for the dengue and also for the two outbreaks. So for this one, I don't know, it's like, what a kind of conclusion that we can say that is it good that the health reform, or we need to do more like what Marianne, she said, like what is their overall effect for the other program? Maybe it's work for the other program, but for some programs it's like you see that. I don't know, because we have to think about the verticality, because there is certain interventions, if you don't think about how you deal with it with the verticality, it's not, I don't know, but this is always come how to do it. It's like for the effect of the program, and also we have to think about the interventions when there is a specific disease. Thank you.
I can tell you that Thailand has very intensive monitoring on the UC effectiveness. For example, they monitor, they hired the polling company to monitor patient satisfaction at least once a year or more frequent than that. And satisfaction is very, very high, 80–90% all times. So people perceive that this is a good service, and from the health service perspective. But we epidemiologists, we look at other angles. We look at what will be the impacts on long term when you got more delays on access to care, more delay on system delay, on diagnosis, on treatments, and the cure rate. We cannot just depend on just one thing, but we look at the data on different angles. I think health reform or universal coverage is very important, but it's not panacea. So you have to speed up, but you have to look at the side effect and try to avoid the side effect by doing research to monitoring and feedback to the planners.
Okay, thank you, Professor. So when we started off this session, we posed two questions. If those questions can be put back on the projector. So the first question, the first statement, whether health, okay, the first one was, is health system strengthening detrimental to disease control? And the second one was, is it an illusion to think that disease control programs can do health system strengthening? And our session today was, we had about 9 presentations that talked about different aspects of health system strengthening and disease control programs. So now we open up this to all of you to reflect on these two questions and the presentations and sort of see on what you think about the relationship between disease control programs and health system strengthening. So raise your hands as you feel you want to share your thoughts.
Thank you. I'd like to share actually not so much my thoughts, but the thoughts of one of the key informants in the study that I was presenting. And he said to me, you see, disease control programs and health systems are like a family. They're like children and parents in a family. And he said here in Asia, the parents support the children, but then when the parents grow up, the children also support the parents, and you have to do it both ways. So it has to be this. So it just struck me now when you were asking the questions that it's a two-way relationship.
Okay, thank you. I think there is the health programs. They will contribute to the strengthening of the health system. If we have really a good vision how it will be done. Because what usually we think as a program people, you think about your programs and you forget. You want to do things as an immediate, and you need to do it in the same, you need to quickly reach your impact on that programs. And this is actually what's happening with, like, there is a very successful diseases. When they did it in that way, they could manage. There is a challenge here with, because I don't agree with some people before in the discussion they said about the donors. We are the one we should, we have to drive the donors. They should not drive us, because if there is a good strategies in the country, and if there is a base of the health system in that country, you move the donors, not the donors move you. Because usually we are reluctant to act what really we need to do. This is the issue. And they can tell you the amount of fund we are pouring to the country towards vertical disease. It can help not only the health system, it can help also the others, the other things that in the country. It's like the poverty and all this. But really, usually we say, oh no, the vertical program they cannot support. We don't work with the health system people. They have their own ways, and they're working there. From the program levels, they think if they put money in a way that to see where they could support the health system or where they can support their areas, they will find it is very, how can I say it? We don't think that way. This is what I noticed myself. I work like, I give my example. I work like almost 12 years in HIV program in Sudan. And it's very, very low prevalence. And we are spending a lot of millions of dollars tell you one good example. Incidence is going up. Coverage of the program, we have a very low coverage, which is like 4%. You can imagine in a country where you have millions of dollars that is spending, we are the worst program in I don't know, in the world, in the treatment coverage, if you see overall the global rate. But if you see the amount of effort and money is being spent, it went like, because we are not focusing on the health system. So now we are back in all our strategy to see where we could support the health system, and that it can get also our way, because with this way we cannot move.
Okay.
Yeah, thank you.
Next question? No, the person, the other person.
Good afternoon. Regarding the statement, the current drive for UHC is going at the expense of disease control. In India, one of the methods for UHC is the RSB by Rashtriya Swasthya Bima Yojana, which is a social insurance. And while conducting a program evaluation in my state, we found that 21% hospitals were in the private sector, and the fund flow to them was to the tune of 68%. So I definitely see that the current drive for UHC is going at the expense of disease control.
Professor.
Right. The comment is about private sectors.
It is the government money which is going to RSB by. It's the public money which is going to as premium to the insurance company, right?
We don't advocate insurance, private insurance. It will skim out your resource. So if you do the insurance, it must be public insurance run by the states. If you promote private insurance, then you, as you said, the money will go to, and then they will skim out.
But RSB
people can have private insurance, but that does not solve the problem of so coverage. The FNC will be reduced. Yeah, I got two comments on the Bruno's and one of the presenters. I think the concept of building blocks is important, and as we say that measurement is not important if you don't understand. Now that we understand the building blocks, I think we should, in the next step, we should try to do some measurement, just like we measure the incidence of the disease. So when we can measure the different part of building block, we can monitor and can make comparison across time or across place. Second is the screening program on TB. I think this is donor-driven, pushed by the monies of Global Fund, which is not sustainable and with very high cost. When there's no such fund, it will not be sustainable. Active case screening is not the main problem. It's more on the case holdings and have to ensure cure rate. But I agree that public education is important. But as you see from the data, that 90% already aware. And in the past 50 years, we got a mobile clinic, chest X-rays in developing countries. But it's very costly. And it's no more because it's not effective. So strengthening the existing health system is more important for TB controls. But you still have to specialize, have to specialize personnel to look after this program, not a vertical program, and not just do the active case scanning, because at what cost and how frequent would you do? Because you start with identify the backlog, but next few years this will come up again, and you have to do the modeling, etc., etc. Overall, you lose some opportunity cost in running such program. That my advice, that don't take the WHO or the Global Fund strategies on these attitudes of spending money on community-based active case findings and just one and finish. This is not the screening for pap smear. That's different.
Great. The gentleman next to Werner. Yeah.
Thanks a lot for your presentation. I wonder if there is no a certain misunderstanding of the word integrating. And following what I do believe is that it's not program that we integrate it in health systems, but at some stage it can be some activities of some program that we can or not integrate at the first or the second level of a local health system. And that's something quite different of speaking of integrated all a program. And it raises a second question: to which extent then we do need manager of health program to which level of the health system? Depending on the country, it is maybe useful in a small country to have them at national level. In some larger country, maybe to have some of them at regional level, but probably not at local health system level. Thanks a lot.
Sunil, that's...
Thanks. From yesterday, I've been hearing words: integration, vertical systems, health, all programs, and there's a lot of suggestions on how it should be done, a lot of advice given. But frankly, let's reflect upon one thing. My position is that it's not possible to have all these things called integration and all that. Because it is against human nature. Frankly, as human beings, we are territorial animals. We have a big ego. We have our tough battles. We like control. We like power. Okay. Now, all of us, many of us sitting in this room, if you really look at it, look at our own organizations. Whether we come from academic institutions, research organization, international organizations, or ministries of health, how much we really talk to each other, how much we operate in our own silos, how much do we really share. And believe me, I have worked in, I continue to work in the Ministry of Health, I work in a research organization, I worked in an international organization, and you really find that it's easy to tell others, but what happens within our own organizations? I think it's a moment to reflect how much we really share. It's nice to tell integration and all that. And I'll stop you. Thank you.
Do you want, yeah?
Thank you, Sunil. I think that was a well-deserved kind of, that was a comment that really needed to be said. Because I've been here only this morning, and at the risk of sounding very provocative, I'm wondering whether analysis can paralyze. Research can paralyze. I'm not speaking in favor of only implementation, and I see that the dichotomy of anything we can produce in our heads, it's amazing. I agree, Sunil, because the minute we say A, somehow it's with reference to B. And anything that needs to take us forward has to be without these references in our heads. Right? And to see that, you have to see the fact of the way each of us behaves in these contexts. Are we open in our minds to listening to people? Because otherwise we can go on having conferences and nothing will move. We can have the researcher versus the implementer, and nothing will move. But I do not share your cynicism in terms of saying that man is a territorial animal and therefore we will continue to have this. I think it is possible, but maybe we have to look somewhere else. And maybe we are looking in the wrong place for these solutions. Because evidently, the wholeness has to come not only in the area of health systems, but if you take social determinants of health, it goes across the board. Then it goes across the board from district level and from the community health worker to the global level. So at every level this thing is happening. You can name it X, Y, Z, A, B, C axis as it goes on. But the point is, where are our minds in this entire debate? What is our sense of willingness to learn from what is happening outside and inside us at the same time? I stop there.
Okay.
Thank you. I'm quite naive on this theme, but to the extent I follow the debates and the literature, I feel that most of the discourse about the interface between disease control program and health system, which I think disease control programs are very well considered as part of health system, this interface is largely among health managers and planners. I wondered, is there any role of community in general to have any say about how their services could be organized, or their role is rather limited to the products? After a long time, I heard Professor Virasaki referring to the satisfaction of the users of particular, in particular country or in particular thing. So I was wondering, has there been any engagement of general public community on this idea of how to organize health service, be it programs, be it general health care?
May I respond? I think first you have to help increase your policy space. The concept of policy space is important for public participation. If the health policy is only in the hands of the health planners, that would be wrong. In Thailand, for example, we have national health assemblies. This is by law. So the National Health Assembly come from people from all walks of life. And they raise an issues every year, what is important, and how can, for example, they say, we need health impact assessments in all major public programs or private programs. And they raise concern on rights of the patients. So the doctor never concerned about this. It must be from the people. So policy space you have to widen. Then you can have more participation. And once you establish the policy, then you can materialize by the programs and resource allocation to support direction of research, how to focus priority settings, and how to instrumentalize, monitor the progress of what is people's concerns. Then you got, this is upstream. So what we are doing, most of the program is downstream. We do research and say, okay, since we got this finding, you should follow our finding. I think that's not a good strategy. You have to say, what questions should be asked? Partly from people, but of course you are scientists. You have to look at disease incident, vector, etc. So there's to strike the balance. We have to make it public communication on both sides, people participations and scientific knowledge.
One question. No, I think, in fact, of course, also in the scheme you have, the community is there, and it's quite central in it. If you talk about accountability and definitely social accountability, then you need to think about it in terms of two people, two parties, two actors. One is the account holder, the other one is the accounter. So you could say, okay, stewards need to keep the providers accountable for what they do, but somebody has to keep the steward accountable for what they are actually doing. And you could look at it in a way as if the steward, and I think we're not yet out of what and whom the steward should be. Is it the district health management team? We know that doesn't work always. So we live in mixed systems, pluralistic health systems with lots of kinds of actors and providers and systems. So probably we'll need distributed stewardship things. We need to think about kind of different configurations of stewards, which also means different accountability mechanisms. And we're not good at this downward accountability. If you don't force it, we don't do it. I mean, we providers, managers, researchers, it is not something that comes automatically. And that's, I think, a link again to the governance and the political thing. And perhaps the bit of the cynical position of Sunil, if it was cynical. The fact is that we don't like to do that. So it doesn't come automatically, and it needs to be enforced. Unless there are specific relations and specific conditions where it's based on trust and reciprocity. Eva?
I take up from where Sunil had mentioned and others had also said, I agree that people are territorial or they want to protect their turf. And I think to a certain extent that can be overcome if we keep the community in the center. And if we say what the TB control person is doing is for the community or the patient, the TB patient. But the TB patient also has other needs, would need to be treated for fever or may get pregnant and would need maternal health. So if that vision is there, rather than just the TB disease, but the person as a whole or the person within the community, then I think we can break these silos. But otherwise, and that is where your role of stewardship and vision and leadership comes in, where you're able to enthuse your program officers and your staff into focusing on the people in the center rather than your program in the center. Thank you.
I think Deva summed it up very nicely, actually. Now I'll ask Bart to say a few words.
Well, I wanted to thank very much the two keynote speakers because I think they did an excellent job. I liked very much the new thinking somehow that Professor Virasagdi has launched, even if we don't have the entire picture, but the fact that the current emphasis on developing the general health system and the endeavor for universal health coverage, that this may perhaps here and there go at the expense of some attention for disease control programs is in a way a bit a new line of thinking which is good to have in the back of our minds. Even if, again, we don't have the entire picture. And I think that Marianne hinted to that, you need a little bit to step back, and perhaps it compensates for things that were unbalanced before. But it's an idea to keep in the back of our minds. In line with this, I also found very interesting what Professor Virasagdi referred to, that universal health coverage may be something shallow. We should avoid to get into slogans, you know, and reduce universal health coverage to quantities, to numbers, and lose a little bit out of track. What exactly do we offer people? What is exactly the package of things we offer people? I found this also a useful idea. I think concerning the statement, well, is it an illusion for programs to strengthen health systems? Yes, I think we have answers there. It's not an illusion. There have been examples mentioned in the experience that it is possible. It's by no means easy. The picture is very varied from one setting to the other, but things are definitely possible. At the same time, I wanted to voice a frustration that Bruno uttered, a small frustration uttered in the break. He says, well, we have very interesting empirical data coming up and experiences here and there, but now it's really necessary to try and put all these in a coherent frame, to populate the framework so that we can, yes, tap all these experiences and learn from it. And that there, I think, is a track for researchers to develop, and I think his presentation is already a good step in that direction, a coherent frame, and then on that basis try to feed it with with the very many field experiences that have been shared here.
Thank you, Bart. I think you've summed it up very well, actually, and made my job easier. And I know that you're all waiting for lunch, so thank you again for attending this session, and it's proved to be a very interesting and thought-provoking one. Enjoy your lunch. Thank you.
Sorry, I'm going to keep you just 2 minutes from your lunch, because I must thank all the 4 people on the dais. They have spent time, a lot of affection in the way they handled this session, so much patience and trying to give everybody a chance to speak. Thank you, and on behalf of the organizers and on behalf of the colloquium, we would like to present each of you with a gift. So, yeah? Oh, they're waiting on that side. I'm sorry. Yeah. So maybe the first one to Professor Virasaki. Thank you, sir. And Krishna Rao, thank you so much. It's been very nice having you chair the session. Professor Bart Creel, inimitable in his summing up, as always. And Bruno Marshall, who I think is a very clever man. Thank you, Bruno. I think we can proceed to lunch, and the session starts at 2 o'clock. 2 p.m. we gather again for the concluding session. Thank you.